and sit down, please. Presentations followed by panel and audience discussion. And our presentation time should be done within 7 minutes. The presentation file will close at 7 minutes. And 3 minutes discussion we are going to have for every presentation. And the panel member, could you please state your name and where you're from? From the, yeah, thank you very much.
Yeah, first presenter, Wahlgren, Sweden.
Ethan Eldenberg, Israel.
Martin Marina, Örebro and London.
I'm Melanie Hoehn. I'm from Shock Trauma in Baltimore.
I'm Yuri Kong from Japan.
Patrick Vriends from Tilburg, the Netherlands.
I'm Lisa Heil. I'm from Johns Hopkins in Baltimore.
And we are Jim Matsumoto from Japan and?
George Oosthuizen from South Africa.
Okay, so we'd like to have the first presentation. So could you start the talk, Dr. Wahlgren from Sweden?
All right, thank you very much. And again, thanks, Tal and the organizing committee for putting this very terrific meeting together. So my task this morning is to talk a little bit about endovascular bleeding control in a multidisciplinary approach in our local institution. So we all know that endovascular techniques has been increasing rapidly over the past years, and we have been all taught from ATLS and DSTC that we can control bleeding in all sorts of ways, combining open surgical skills, endovascular skills, and also in a multidisciplinary approach, work together with our colleagues with resuscitation, hemostatic resuscitation, and together with the ortho guys to stabilize patients and control bleeding. It's important to emphasize, I think, in all discussion here that we need to do this in as a rapid way as possible, and the treatment of bleeding is to stop the bleeding, and we can't delay that. So, from an open perspective, vascular control or bleeding control can be divided in a couple of phases. This is modified from Mattox and Hirschberg that we need to temporarily control bleeding in some sort of way. We need to expose the injury. We need to have some kind of definitive control, and then we need to decide: is this a patient that tolerates a definitive procedure? Is the physiology okay? Or do we need to go into a more vascular damage control mode? In all these phases, we can apply endovascular techniques, and we've been trying to, I suppose all of you have been trying to push this more forward and put in these techniques in all these phases. We can control temporary bleedings with the REBOA and move the patient, transfer the patients to maybe the operation theater. We can use other techniques with occlusion balloons, embolization, and move this forward into the operating room at an early phase. And we can also use stent graft as a bridge or a temporary solution, or in a more definitive way. But this is truly a collaborative way of working, that different surgical specialties need to work together: interventional radiology, anesthesia, transfusion medicine, orthopedics, ER, other physicians are involved in this collaborative way to control bleeding. This is our own institution, how it looks like, and I just want to emphasize the importance to have all these facilities close to the trauma bay, to the trauma resuscitation area. We need to have the trauma CT next to the trauma bay. We need to have the theater next to the trauma bay, and we need to have either a combined theater or a hybrid suite very close to the trauma bay, just to eliminate patient transfer, eliminate the choice where to go. We need to have everything just nearby to be able to do the best for the patient. This is our hybrid suite where vascular usually do elective work, and we move patients when we have more acute cases, trauma cases, bleeding cases, and these are all the stakeholders involved: trauma, ortho, OB bleedings, gastrointestinal bleeding, but also more elective settings where we use balloon occlusions for tumor surgery, for example. This is just another view of the suite, and I know many of you have these suites, of course, but I know that some of these suites are more far away from the trauma room and from the ER, and some are very close. But we try to also move in other techniques. ECMO, for example, is probably a very interesting technique for the future that we still need to discuss the indication for that. These are the techniques we usually discuss. REBOA, balloon occlusion. Balloon occlusion is good not only to try to control the bleeding, but also maybe to help the surgeon, to guide the surgeon in some difficult anatomic areas. It's been very helpful many times just to know where you are. Angioembolization, stent graft, and also for maybe iatrogenic injuries, arterial closure devices. There are a lot of data on endovascular techniques, and especially embolization for solid organ injuries, and there are more and more data on stent graft as well, and moving that in a little bit more earlier phase. This is our own data on embolization, quite wide range of looking at the age, but still a young population, mostly men, only 30% women. Blunt trauma is always dominate in Sweden, and of course for embolization it is more solid organ injuries, and the internal hypogastric artery is the most common artery, and followed by the visceral arteries. About 1/3 of all these cases be done together in conjunction with the laparotomy. Just give you a couple of examples of this is a MVA with splenic injury with proximal embolization, just to reduce the perfusion in the spleen. This is our protocol. It's a modified protocol together with the Ullevål Hospital, where we try to push embolization in patients with normal physiology and extravasation on the CT, and that could be a consideration for embolization. There is a randomized trial planned right now for the more severe injuries. That is a more international collaboration trial. This is just another example how we can control bleeding from solid organs. This is a liver injury. You can see the blush on the CT, where after angiography there is extravasation, and it can be coiled in a fashion that probably most of you are familiar with. Stent grafts are moving in. We have a lot of experience worldwide with the stent grafts for aortic injuries in the proximal descending aorta, but also stent graft for injuries like this could be in selected cases possible. This is stab wound to the thigh, quite extensive incision just to put in the interposition graft. In selective cases, maybe stent graft could be possible. This was the week after, stab wound to the thigh as well, and the stent graft was placed because of other multiple injuries, and it could be looked as a bridge or a more definitive solution to bail out. But of course, this takes time. This is our median time, a couple of years old, but still I think it's appropriate. From hospital admission to embolization, it's about 3 hours. And this, of course, all patients. So it's a long time. But I think, when you look at your own data, I mean, it's longer than you actually expect. Of course, there are patients that are embolized within an hour, but most patients, probably, of course, because of indications, but it is longer. And we all know that delay to this could be associated with mortality. So to summarize this is truly a collaborative thing. A lot of specialties are involved, and we need to work on facilities to facilitate this, just to eliminate time and to minimize patients' transfers. Thank you very much.
So, any comments or questions from the audience or from the panel? So, George, do you have any?
Dr. Wahlgren, I have a question for you with regards to the hybrid theater. Do you have a protocol as to which trauma patients proceed to the hybrid theater as opposed to which ones go to the ordinary operating room?
Oh, that's a very good question. Actually, we really don't have a protocol, but I would say actually all patients that are bleeding patient and could be where we could have use of any endovascular skills combined with open should go there, but we don't have a strict protocol for that. I have to say that, and I think that's something we should have. And it's also the setting in our hospital is that we probably underutilize a little bit the hybrid suite. A lot of patients that have really severe injuries there is a emergency theater just next to the trauma bay, but the hybrid suite is 10 yards from the trauma resuscitation, and those 10 yards, 10 meters, are a little bit of a threshold. So it's easier to go into the theater next to the trauma bay than go to the hybrid suite. So some of the really severe injuries go directly to that theater. But I agree with you that that's something that selection is very important and something we need to work on.
And perhaps just a follow-up question with regards to the REBOA. If you identify that a patient needs REBOA placement, do you place it there in the emergency room and then proceed to the hybrid theater, or do you go to the hybrid theater and do it there?
Yeah, I think usually, because it's so close, usually the REBOA ends up in the theater. And there are very few cases we actually done in the trauma resus area because it's only a very short, it's only a minute to transfer the patient. And of course, it's about safety and of course selection of these patients. I mean, our protocol is a little bit of a modified protocol from shock trauma and some of the other protocols out there. And in patients with, especially maybe I would say pelvic fractures and patients that are transient or non-responders, those are the patients we put it in, and usually that ends up in the theater, maybe waiting for embolization or together with laparotomy. Just to minimize any delays, I would say usually it ends up in the OR together with all the X-ray facilities we have there.
So, I have one question for you. How do you divide your patients with the interventional radiologists? For example, if you see the splenic injury, what patient do you send to the interventional radiology? What you put automatically into the surgical theater? Because some of the patients are stable, you have time in order to do a splenic embolization. It takes time. Yeah. It's about half an hour.
It's a good question. Thank you. And it's a joint effort. It's a joint effort.
Excuse me. The thing is need more discussion, I think. So we have another 15 minutes at the end of this session. So could you talk about that in the
It's a collaborative thing.
Yeah. Thank you. Sorry. So let's move on to the next talk.
Good morning. I'm very happy to be here. I'm going to show what the radiologists can do to help in the trauma management. That's my job today. Luckily, Dr. Wahlgren already gave all the information, what to do, the protocol, this and that. I'm going just to show quickly all the cases, what do we do, and how do we do just in 7 minutes. 6.5. By the way, nobody has mentioned here neuro cases. I don't know if you or somebody does, but we do in our institution the neuro intervention as well. And also nobody has mentioned pediatrics, which is so important. We have a lot of injured children in our institution. This is where we can start. This is a young boy, teenager, bullets here, bleeding from the superficial temporal artery, embolization. This is a 15-year-old boy, bullet in the neck, rupture of the carotid artery. We put a stent. We had to do angiogram, make sure that the other side is patent. And this, we do vertebral arteriogram, everything to make sure there is collateral flow. In the case we have to embolize the carotid artery or the vertebral artery, which we do relatively often. This is another case of a bullet in the carotid artery. Oops. And then the infections superimposed, and this is what is called the carotid blowout syndrome. So we can put a stent, but this is here all infected. So it's better to just embolize the carotid artery there. This is nephrology people trying to do a dialysis catheter, and they put into the carotid artery. So we pull the catheter out, and then we put a stent and take care of the problem. This is You can see after we remove the catheter, a hole in the carotid artery, well fixed by the stent. This is another case of nephrology putting catheters into the internal jugular vein, but this time into the aorta. And then we put a stent and briefly fix this in a few minutes, 5 minutes. Stabbing in the chest, rupture of the lateral thoracic artery, and we selectively catheterize with microcatheters, embolize, and this takes 15 minutes. A bullet in the neck, almost destruction of the subclavian artery, fixing very easily with a stent. Another case of bullet in here, with a stent. This is iatrogenic causes of trauma. We haven't mentioned over here, but iatrogenic is one of the most important causes of trauma in the United States. At least is the number one cause of death, but nobody says this. 800,000 people are injured by us doctors, more than cancer and cardiac diseases. Thoracic biopsy, followed by a massive hemothorax. We embolize, we selectively catheterize all the lumbar intercostal arteries, and even if we don't see bleeding, we embolize empirical embolization with gel foam. By the way, we prefer gel foam because it's recanalization, and most of our patients are young, so it's better for them to do stabbing in the neck, stenting, rupture of the innominate artery in a car accident, fixed by stenting, stabbing in the chest with arteriovenous fistula, stenting, bullet in the chest with pseudoaneurysm of the pulmonary artery, embolized with coils, bleeding into the liver is one of the most important organs. As you know, we have zillions of them, massive bleeding, and then we just embolize without impunity the whole liver. Spleen, we embolize the spleen easily with coils. More of the spleen, cerebral spleen, embolization. Massive rupture of the liver, embolizing the entire hepatic artery with coils and gel foam. We don't worry too much unless there is some portal hypertension. Bleeding in the liver, more liver, more liver, more liver. This is important, pelvic bleeding, massive bleeding from everywhere. What we do is just selectively catheterize both sides with 2 teams, embolize everything there without impunity in the young person, and then you have to embolize with particles or gel foam. I don't think the ballooning, the REBOA is going to work in here because the bleeding is from collaterals. Nobody has discussed this in here. It's important. More bleeding in the retroperitoneum, massively bleeding from the kidney, embolized there, bleeding in the kidney. Massive retroperitoneal bleeding from the adrenal, the kidney is okay, and then we look for adrenal bleeding, embolization. This is very common in our institution, and I'm sure in yours too, bleeding into the abdominal wall due to hypercoagulability or sometimes sticking needles for heparin treatment, and we just selectively catheterize the inferior epigastric artery, embolize. Rupture of the iliac artery, stenting, rupture of the internal iliac artery, embolization, more embolization, arteriovenous fistula due to cardiac catheterization, with stent and fix that. Conclusion, interventional radiology plays a very important role in the management of traumatized patients in the trauma level institutions. I don't have too much time to show this, but I will in maybe less than 1 minute. Trauma-inducer kills more people than the war. We have the problems we call accident when they are drunk driving. We have the right to bear arms. the driving of the young children. That is great. So, thank you.
Thank you for the great cases. I love those cases.
Comments?
And then any questions and comments from panels or discussion?
By the way, all of these procedures are done very quickly. We have to be available in the hospital in 30 minutes. The patient may be ready for us to see the patient in 30 minutes. I think the previous speaker says 3 hours, so we have to improve that.
From Brazil. You've presented several cases of embolization, but do you use the aortic balloon before or during the procedure of embolization? Do you think it's important?
I never use the balloon because it's a new concept. I mentioned yesterday in my institution we still don't have the balloon. It's in some research protocol in Baltimore, a city nearby. Eventually it's going to be coming to us, but I only know one case that we use a regular balloon, like the balloon for the aortic dilatation for the grafting in the inferior vena cava when there was a rupture of the cava. So I had no any experience in ballooning, just embolization or stenting. And by the way, like I said before, we can do catheterization of both internal iliacs, like I showed the cases there, with 2 teams in maybe 5-10 minutes.
Okay,
and
thank
then
you.
embolization in half an hour maximum. Right away, patient recovers.
Thank you for your comments. So, thank you very much for the great cases. So, let's move on to the next talk. Dr. Delle and Dr. Falkenberg from Sweden.
Good morning, everyone. Thanks, Tal, and everybody for having us here. So, I'm Morten Falkenberg. I work in Gothenburg, Sweden, and together with my friend Martin Delle, we are trying to do a joint presentation now. So we both work in for Swedish in Sweden, fairly big hospitals in interventional radiology departments in Stockholm and in Gothenburg.
So this slide we had as an initial slide just to frame the problem, so to say. We know that all this fancy stuff with machines and coils and plugs and whatever we use give us great possibilities. It's a really edge technology, but the problem is not often those things. The problems are the challenges that we meet when we should put all these jigsaw puzzle pieces together to a working unit. Time is, as you know, a precious thing in these matters, and the difficult thing is to get a smooth line in the caretaking of the patient. It's about patient priorities, it's about team building, it's about logistics, it's about education. And that, in our opinion, is one of the greatest challenges.
So what are the tools that we have available? Well, we are going to hear a lot about occlusion balloons at this meeting, and that's a fairly new tool for most of us. I think those of us who have been working in vascular surgery and vascular intervention aorta, we are used to using balloons in ruptured aneurysms, but I think very few of us have a great experience in doing it in trauma cases. The other options that we have to work with is embolization of different kinds, coils, particles, other stuff. So that's a more permanent solution. And thirdly, to repair the vessel from the inside by relining it with covered stents. So in principle, these are the 3 endovascular tools that we can use in trauma, I think.
So, as you might know, we have quite a golden tradition with great names putting the trends in the history of interventional radiology. And if we look into the future, we think that there is a positive trend in Sweden now to develop the IR concept, because IR is about to be recognized as a subspecialty to radiology, and with that we also get a curriculum and formal educational courses and so on. And from now having about 75 interventional consultant radiologists, we hope that we can increase that number, and by increasing that number we can also cross-train and educate other specialties to reach the necessary competence to take care of, for example, trauma patients. We also see an increasing trend also in the medium and small hospitals that there is a need for endovascular means in the taking care of trauma patients. So I think this is very important that we have a growing competence in all specialities.
So a little bit about Sweden. We just recently became 10 million people in this country. It's a fairly big country in size. There are somewhere between 35 and 40 hospitals providing emergency care. But interventional radiology is available, I think, in let's say, 7 cities in the country, in this that you can see here. So most of the country still, some of these treatments are not available, but in the big cities there are.
So to return to the challenges we speak about initially, both Morten and my experience when we discussed this presentation is not on the technical side, but it is to get the different pieces of the chain to work together and create strength. And the human factor is not seldomly a thing that takes down the effectivity in this. So I think that the greatest challenge is to get different specialties to work together and accept that hybrid rooms and so on are situated at the OR or in the X-ray department or whatever. Today, fancy equipment is standing quiet and not used during nights because the different specialties can't reach a solution to get there on call.
So I think it's also important not to underestimate the importance of having trained personnel, trained nurses being around to help us doing these procedures. It's not really easy for a traditional open surgery assistant nurse to switch gear and start doing endovascular work. I think that's a big challenge that we're also facing. We're not just have to educate more doctors, we also have to train nurses. This is the result of a survey that we did a year ago. We asked around on the big Swedish hospitals, what are you doing in your new hybrid suits? And as you can see, there are a lot of procedures being done in these rooms. So there is some sort of competition about getting into these facilities. And trauma is one of them for sure, but that's a logistic challenge also.
And to end up, it could be worth mentioning in the future, I think we agree upon that education is a key issue to reach a better flow in the trauma care. It doesn't matter who does the procedures, for example, in the emergency room. The important thing is that the one doing it is the first on the patient, early in the patient, and have the skills to do it.
Yeah, and how to do this this training and education, that's a problem. We talked about it, and using simulators more, I think, could be a key in this, actually, because these are procedures that are done fairly seldom, and you need to know how to do them when they happen. So that should be a good case for simulator training, I think. Yeah.
Thank you.
Thank you.
Okay, thank you for the presentation. So is there any question or comments?
Thank you very much for a very inspiring talk. And you set an example of how interventional radiologists and vascular surgeons can collaborate, at least on stage. Are you actually performing these procedures together in the hybrid operating theater?
Yeah.
Yes, we are. We used to work in the same hospital, and I came from open surgery. Martin taught me about endovascular procedures. Now we live in different cities, but yeah, we are always working together.
You perform the trauma procedures in a hybrid OR with a surgeon and an interventional radiologist together.
To be totally honest, the availability to the hybrid OR room is for us a really limiting factor. We would love to do more of these procedures in trauma cases, but that's our main obstacle.
My other question was, how do you train your team? Because I think, as you stated, that's really important too.
Well, training is mainly young residents that we have during daytime in elective procedures, and then as they grow more skilled, they are allowed to take part in their on-call service and so on. And we try to educate both vascular surgeons, young vascular surgeons, and young radiologists. But I think we have to rethink and also educate anesthesiologists and emergency doctors when it comes to the immediate care of trauma patients. So it's not good enough to be 30 minutes on call when you have a dying patient in the room. That you have an emergency doctor, and he must be able to do these means with a REBOA and so on. So that's a challenge.
Dr. Tisnado?
Thank you. I would like to make a comment. I would like to pay homage to this country, Sweden. This is how everything started here in Sweden. The doctors from Sweden mentioned Dr. Lunderquist. Dr. Lunderquist was a great angiographer. I don't know if he's still alive, and he designed the wire that we still use in the United States. But you forgot to mention the giants of the angiography, Dr. Olsen and Dr. Boysen, Eric. And they were teachers of us in Philadelphia. They used to go to Philadelphia, to the University of Pennsylvania. I was trained in Jefferson, and we always listened to them. As a matter of fact, in my time, when somebody wanted to be an angiographer, they had to come here to Sweden to learn here because we didn't have over there. We have angiography, basically. And as a matter of fact, the first catheters that we used to make in the late 60s used to be material ordered from here, from Sweden, called Kifa material. I don't know if you still remember, but it would be interesting in you to review the history, because the first article, of course, on the technique of Sellinger was published in the Acta Radiologica, 1957. Thank you.
Thank you very much. Ante, please will you reserve your question for the discussion session later. Our next speaker is Dr. Jun Matsumoto, who's going to share with us the Japanese experience.
I'd like to talk about the EVTM IR view of a multidisciplinary approach. And CT and IR are not recommended to utilize for hemodynamically unstable patients. So we need to have something time conscious for those patients. So we have suggested PRESTO concept. And PRESTO abbreviates, is an abbreviation for prompt and rapid endovascular strategies in trauma occasions. And let me explain the concept, dividing the whole process into 3 stages. In the initial stage, you have to activate IR team prior to the patient's arrival, and like this. So we have trauma code in our institute, and we don't have a trauma surgeon. So in that situation, we need to call a general surgeon, an orthopedics, neurosurgeon, an IR, and an anesthesiologist to the emergency room, and we need to get together prior to the patient's arrival. And it is also important to put arterial cysts during primary survey, so we encourage them to get as many access as possible, artery, vein, any access, we try to get as many as possible. And it is also important to prepare for transfer during primary survey, not after primary survey. During primary survey, we ask the nurses and radiology techs to check the the lines for IV contrast for CT, and to arrange the lines and tubes, and remove unnecessary metallic objects, and fix, if possible, to fix arms and legs for CT scan during primary survey. And on the second stage, you need to have specific CT protocol for unstable patients. What important thing is to train the whole team, including nurses and radiology tech, doctors, to train whole team. And with training, you can decrease the time for CT room stay time, not the examination time. From the entrance of the CT room to exit of the CT room, you can reduce the time. Our team started from 20 minutes to 10:30, and now the average time is 7 minutes and 30. And we are aiming less than 5 minutes, and 5 minutes is too long for unstable patients, I know, but if you can get great, very useful information from CT, that can make your operation or procedure shorter, or you can do those with better strategies. So I think it is important to train the whole team and make the CT room stay time as short as possible. And even in the evaluation of the CT image, you have to have right method. We suggested focused assessment with CT for trauma. In that reading method, you have to evaluate pre-selected areas and injuries, and you have to finish the evaluation process in 3 minutes. And then that makes you, that enables you to take the patient directly from CT to the angio or hybrid suite. And even in the ER, right after CT, if you can finish the evaluation during examination, you can start hybrid management in the ER immediately after CT. Or even for surgical cases, I go with the team and I keep on reading in the OR, and they give more direction to the surgeons. Like we have duodenum disruption or pancreatic injury, so you have to cut in deep kind of thing I can give. And on the third stage, this is the most important part for us, is we have to apply damage control concept even in the interventional radiology procedure. In that procedure, you have to do extremely time-conscious procedure, like single artery embolization time should be less than 10 minutes from the catheterization, embolization, and the confirming arteriography. Those processes should be done in 10 minutes. So if you have bad pelvic fracture and splenic injury, you have to embolize bilateral internal iliac artery and splenic artery. So in that situation, you have to embolize 1 to 3 arteries. So you have to finish whole process in 30 minutes. So if you know where to embolize, you have to skip diagnostic arteriography. And it is also important to allow wide range, non-selective embolization, because we need to save life, not preserve organ function. It's not the purpose goal. So in that situation, we need to allow wide range embolization. And also, this is important to select the right embolic agent. We aggressively use NVCA. It's a kind of glue, super glue. And if you use that, it acts independently on coagulation status, and it acts instantly, embolize the artery. So in that situation, in unstable patients, most of the patients are coagulopathic. In that situation, coils and gelatin sponge particles, they act dependently on coagulation status, so it can take more time with those embolic agents. So that's why we use this kind of embolic agent. And it is very important to be flexible in changing devices, operators, and methods. And temporary balloon occlusion is, one of the great options. And during the process, it is very important to put someone outside the angio room and to have an anesthesiologist to make a procedure less invasive. So if you have a conductor outside the angio room, so he can give anatomical information, or he can say, we need to stop the embolization. Why don't we put the balloon up and take the patient for the full-up head CT kind of direction he can give. So we need to have someone outside. Then the operator can focus on the procedure, and we can make the whole process shorter. So with this concept, I think if you can save time, it means you can save life. Thank you for your attention.
Thanks, Jude. Are there any questions or comments from the audience?
I have a comment and then a question. First of all, congratulations to you and all of your colleagues for your experience and for so expertly communicating them to us today. The question is about, we've talked about saving lives and stopping the bleeding. Do you have a sense with your experience and that of your colleagues as to saving blood products? I mean, I think we spend a lot of time talking about resuscitation and stabilizing the blood pressure and saving lives, but I think in the back of several of our minds is, are we actually also saving or have a more judicious use of blood products? With your experience in this sort of rapid or PRESTO approach, have you done any studies to show better utilization of blood products?
We don't have data, but our indication is so wide. It partly because of if we start the procedure earlier, we can decrease the volume of blood products. So that is one of our concept. Yes.
It's okay. June, Tal, one quick question. You're using a CT on rails now in Japan. As I know from my spies, you have 8 CT on rails in the ER in Japan. I would like to ask here, also in the people here on the stage, if they have any experience with it, if you, June, or you guys, CT in the ER, CT on rails, and if you feel it's time-saving. Thank you.
I don't have, so someone can answer.
We don't preconize the CT on emergency situations with shock, but we have to learn with the Japanese people. I have to ask, do you use tomography as a routine ever, or it's because you don't have general surgeons or emergency surgeons on your emergency room?
We aggressively scan the patient, and most of the time, the whole team are together. So, and we can discuss over the CT images. So, I think we don't have any delay during the process. I think so. That's why we use those aggressively.
We in Tilburg, we have 2 trauma rooms with 1 CT scanner on rails in the emergency room department, and 24/7 trauma surgeons in the hospital, and the 2 are time-saving and life-saving, I think. But a CT on rails is really goes fast. Really.
Great. That brings us right up to time. Thank you very much. Our next speaker, Dr. Joe Love from Texas.
Well, good morning, everybody. I was tasked with covering the who, what, when, and why for endovascular management in the trauma situation, and to do that in 7 minutes. So here it goes. If I can get that slide to work. Oh, no slides.
Yeah.
Well, go ahead.
Yeah, could you present that slide? You don't have any slide?
Oh, there's slides. I sent them. Okay. So, what? Yeah, let's do that. I get a reprieve for a couple minutes, and then we'll do it in 7. So stay tuned.
So the next one, the next one will be ready. So Georgie will talk. We need to be time conscious. Okay.
All right, we'll get started with the next talk while they sort that out. I'm George Oosthuizen from Pietermaritzburg, South Africa. I'm a trauma surgeon by trade. And I'm talking about, is EVTM relevant in South Africa? If you look at the literature, there's an abundance of literature from South Africa on catheter-directed embolization and stenting of arterial injuries. So we've ticked that box. With regards to REBOA, the new kid on the block, it is not something that's been taken up in South African trauma surgery practice as yet. Currently, there is no dedicated REBOA balloon available in South Africa. What we do have available is the Reliant stent graft balloon catheter. That's from Medtronic. It's a 12 French catheter with it comes with a 14 French sheath, and it's used for abdominal aortic aneurysms. Frank Plani and myself are currently working with a company called Tai Chi Holdings to import the Tokai, the rescue balloon from Tokai Medical in Japan. So hopefully within the next couple of months or so, we'll have those on our shelves in South Africa. Just a bit of personal background. I met Tal in 2014, and he then shared with me the REBOA concept, and he wanted me to join the movement, as it were. I was very skeptical about it. I said to him, South African surgeons open up and we clamp. But you know, if you know Tal, you'll know that he doesn't give up. And 2 years later, he convinced me to come to one of his REBOA workshops. I attended that last year in September, I think it was. And about a month later, back in South Africa, I performed my first REBOA case. Now, it was a modified REBOA case, but it was a REBOA case nonetheless. And as far as I know, it was the first REBOA case in South Africa. I'll share it with you briefly. It was a 30-year-old male that had a gunshot wound to the right hypochondrium, as shown in the diagram, exit wound, left posterior flank. He was a transient responder. We proceeded straight to the operating room and did a laparotomy. At laparotomy, he had an injury to the right lobe of the liver, which wasn't bleeding actively at the time, and he had a large pulsatile bleeding hematoma sitting in the epigastrium with about 2 liters of blood in his belly. It was impossible to put a clamp above this large pulsatile hematoma in the abdomen on the aorta. So I had 2 choices available to me. Either I could open up the patient's chest and cross-clamp the aorta, or I could put in a REBOA. And it just so happened that I had a sample of a rescue balloon sitting with me in the theater, a 7 French Tokai balloon. And so I decided to use that. Now, it was easy because I had the abdomen open and the aorta was right in front of me. So I just displaced the small bowel and put the sheath straight into the aorta. So that's why it was a modified REBOA. But I fed the balloon up into zone 1, occluded the aorta, and it gave me very good visibility. I could see that there appeared to be an injury to the celiac trunk. I did a medial visceral rotation. And indeed, the bullet had shaved off the celiac trunk flush with the aorta. So where the celiac trunk was supposed to be, there was just a defect in the aorta, and the branches of the celiac trunk had been blown apart. During the course of that dissection, my assistant, who was supposed to be holding onto the REBOA catheter, wasn't doing her job properly, and the balloon was being pushed down in the aorta. And soon enough, I had major bleeding again in the operating field. However, by then I had seen what I wanted to see, and it was very easy for me to put a finger on it, put a clamp above and below, and to deal with the injury. So I oversewed the defect in the aorta. There was absolutely no visceral ischemia. So I oversewed the defect in the aorta, and I ligated the branches of the celiac trunk. Did a temporary, I packed the liver, did a temporary abdominal closure, and went to the ICU. Patient was initially on inotropic support, came off inotropic support within the next few hours. The lactate cleared very well over the next few hours, and over the next 2 or 3 days, the patient had very mild acute kidney injury, which settled beyond day 3. Day 2 post-op, I took the patient back to the operating room, relook laparotomy, I removed the packs off the liver, left a drain to the liver, and there was no visceral ischemia, so closed the abdomen. The patient had an uneventful recovery. He was up and about by day 5, and the only thing that kept him in hospital for another 10 days was a controlled biliary fistula, which eventually dried up by itself. And he went home, and he's currently well. Now, is REBOA relevant in South Africa? When you look at the literature, REBOA seems to be equally beneficial to patients in blunt and penetrating trauma. Myself and Orfa Meron will be sharing some of that data this afternoon. And in South Africa, we have a high incidence of penetrating trauma and an ever-increasing incidence of complicated blunt polytrauma as well, vehicle-related. So is REBOA relevant in South Africa? I would say definitely. The Trauma Society of South Africa, we currently neither endorse nor oppose REBOA what we are saying is that we're encouraging scientific exploration in this area. Just in my own practice, over the course of the last 12 months, there have been at least 3 cases that I can think of that I think may have benefited from the use of REBOA. Patients that had gunshot wounds to the pelvic area and that exsanguinated in the course of their operative management. So in summary, I shared with you the first REBOA case in South Africa. Yes, it was a modified open technique, but it helped me to avoid opening the patient's chest. The patient made a rapid recovery and is currently well. Would I do that again in that same situation? Definitely. I think it helped the patient. In conclusion, I think there's a definite role for REBOA in South Africa. Of course, each unit will make their own decision about that as we go forward. All going well, we should have the rescue balloon from Tokai on our shelves in South Africa fairly soon. And of course, we will proceed within the bounds of science. Thank you.
So, any questions or comments from the audience, panels? Okay.
It was either very clear or very unclear.
I think you're putting the balloon in the right context. I've been using balloons for very long in context with ruptured aortas mainly, and it is a great tool, but I think it should be used wisely by people who are used to treating bad bleeders, because the balloon is fantastic if the patient is dying right there in front of you, but you shouldn't be using it prophylactically. I've also seen massive thrombosis of the aorta from balloons used perhaps too liberally. So it's a great tool if used by people who are truly familiar with big bleeders.
Yeah, maybe just on that point, you know, as I said, we see a lot of penetrating trauma, very severely injured patients. But I sort of, just thinking back over the last year, I could think of 3 cases that I thought may have benefited from the use of REBOA. I'm not saying I could think of 30 cases or 300 cases. I think the indications are still quite limited. And I certainly won't be using them left, right, and center in my practice.
Another comment? Oh, yeah, over there.
Yeah, I have a quick question. Ragnar from Trauma in Gothenburg. I'm right here. Before exploring the zone 1 retroperitoneal hematomas in penetrating wounds, I've learned the hard way that it's very good to have proximal control, and a bit like it touched your case a little bit. When you explore that retroperitoneal hematoma, it's going to be mayhem. Obviously, it's not as easy as it sounds. How proactive do you think you'd have to be, and would you advocate to put a balloon before you start to exploring a zone 1 pulsating retroperitoneal hematoma, or would that be too proactive?
So, if I understand your question correctly, I think it's critical to have proximal control before you enter that sort of injury. Whether it's, usually don't know what it is, whether it's a vena cava injury or an aortic injury, but I think it's critical to get proximal control, either with a clamp or with REBOA. And before I started using REBOA, I would always, in that setting, with this large hematoma sitting in the epigastric area that you couldn't get above, I would always open the chest, put a clamp, and then proceed.
So that's the answer. Before you proceed, you'd have to control, and before you proceed, you'd have the balloon in place.
Yeah.
Can I just comment to Gio? Some of us, George is doing this laparoscopy. What was the time of the surgery, total time, when you got there? 1.5?
Less than an hour, I'd say.
All right, and you think about a resident in Sweden or myself doing a celiac artery injury. Would it help with the balloon in that sense, the speed of the surgery, for the unexperienced people?
Yes, definitely. I would say so. In fact, I'm going to be training or making sure that my residents get all the necessary training, that they do the same. Yeah.
Could you have placed a stent graft?
Sorry, come again?
Could you have covered the celiac orifice with an aortic stent graft?
If I had them available in my institution, yes, but we don't.
Just one short comment, please.
I think, Tal and I were talking, I think it's also, we shouldn't overlook blood loss. So I think Joe DeBose will present experience 3 or 4 cases that were done downrange in a very austere location where we don't have access to units and units of blood. So I think the point about proactive control of a zone 1 retroperitoneal hematoma, using this as an operative adjunct to decrease, not just to save the patient's life or not, just to decrease blood loss and improve physiology, especially in locations where we don't have access to a lot of blood, is, I think, very important and shouldn't be overlooked. And in part was my question, I think, to before, the previous question was, you know, getting data on blood utilization, and probably would potentially see benefit there. Thank you.
Okay, so let's move on to, thank you very much. So let's move on to Dr. Love.
Thank you very much. Technical difficulties aside, I believe we're ready to go. So I believe that the use of endovascular techniques, specifically blood, to occlude bleeding vessels in a significantly injured pelvic patient. And to be fair, their imaging and technique was fairly decent back in 1972. So how did we get to this point where we're discussing the management of patients today in Örebro, Sweden? There's pretty decent equipoise when we start talking about the management of solid organ injury and the utilization of embolization for those patients. And it started likely from the non-operative management in children, where we don't take out as many spleens or operate as much as we used to. And that spilled over into our trauma population for the adults. And to be